Welcome to first session of MRCOG2 by MRCOG Hub. First, I will give you a brief introduction about myself. I'm Dr. Sana Hafiz. I did my MBBS from Kailasan Medical College, Bahawalpur, and I did FCPS in Obs and Gynae in 2016. I completed my membership exam from Royal College of Obstetricians and Gynecologists in 2022, and I've also obtained a certificate in health professions education in 2023. I'm currently working as assistant professor at Shahida Islam Medical and Dental College, Luthra. So in this session, we will discuss about important exam dates of MRCOG2, what syllabus we need to cover, what are the sources and practice books. And I will give you a brief overview of different courses which are offered by MRCOG Hub. We will do discussion on one guideline. I have chosen a guideline on management of ovarian masses in premenopausal women, and then we will do quiz related to that guideline so that you have an idea how our course will work. So what is MRCOG Part 2? It's a membership exam, as the name shows, of Royal College of Obstetricians and Gynecologists. In Part 2, theoretical knowledge and clinical application of that knowledge is judged. Basically, it has three parts. Part 1 is about basic sciences, as you have already passed that part, mashallah. And Part 2 is about application of that knowledge. And part 3 assesses that knowledge clinically. So actually part 2 and part 3 are same. In part 2 you are assessed that how you apply that knowledge. And in part 3 you have to perform in front of examiners. So aim of part 2 is to assess ability to apply core clinical knowledge for safe practice. So whenever you read a topic, try to think about the real life scenarios, how you will apply that topic in the real life scenario. It will make your life easier and easy for you to practice questions in exam as well. So exam format of part 2 is that it is written exam only, it's online exam, and there are two papers, each of 3 hours duration. The 50%, each paper consists of 50% single best answers and 50% are extended matching questions. The source for the exam is the Green Top Guidelines, NICE, and TOGS. The main portion of the exam comes from Green Top Guidelines and NICE. And those topics which are not covered in these guidelines, these are assessed by TOGS. And only you have to do some important TOGS. Some people say that you have to do TOGS from last 5 years or 3 years. It's not as that you have to cover all these TOGS. You have to do TOGS on only important topics. For example, there's no guideline, NICE guideline or Green Top guideline on asthma in pregnancy. So you have to do that from TOG. I will share those talks that you have to read for preparation of MRCOG Part 2. So you have to solve past questions and exam practice books. As much as possible, you have to do maximum practice from the question books. There are different books having MCQs and EMQs. Try to practice as much as it is possible, and also do recalls. But because in the exam, many questions come from past papers as well. Attend revision courses and make study groups. It's best if you have a study buddy. If don't, then don't worry. Practice by yourself. And focus on clinical reasoning, not just memorization. This is an extensive syllabus for MRCOG2, starting from clinical skills to urogynecology and pelvic floor problems. I will share this recording with you as well after the session. So we will cover these modules during the whole course, and each module will be assessed by some tests, which will include maximum number of recalls from past exams as well. Sorry, it's part 2 exam dates. There are 2 sessions in January and July. In January 2026, exam will be on 15 January, and the expression of interest will close on 9 September 2025. Booking window will open on 21st October. And keep in mind that you have to book the exam immediately when the booking window opens, because the seats are sold immediately. And booking window will close on 9th December. Exam date is 15th January and result will be released on 11th Feb. So the different courses which are offered by MRCOG Hub, these include weekly schedule of topics which we are going to study. We have a daily read a topic and practice questions related to that topic from question book. Then we will share questions in the group from different books, or even I'll share some questions from the past papers as well. Then we will discuss those questions in the group and we will discuss difficult or ambiguous questions. At the end of the week, there will be assessment on Socrative. Socrative is an app. It's very easy to use. And then there will be discussion which will be live or recording on Zoom. You will also get summaries of the topics in few courses, and we will have some live sessions regarding important points which are to be discussed in the exam. There are different kind of courses, so I will share the details of those courses in the group with you as well, so you can check which uh, things are included in which course. So let's start with the first session. I have chosen a guideline on management of suspected ovarian masses in premenopausal women. This guideline seems to be very easy while reading. However, many questions come from this guideline in the form of EMQs or MCQs. So we'll briefly discuss a summary of this guideline. This is a brief guideline. However, I have also tried to make a summary of that. And after reading that summary, we will do the quiz. So you have to try to understand the summary. In the course, what will happen that you will have to read the whole guideline for the first time. I will provide with you the summaries or the highlighted portion of the guideline. I will guide you which part is more important. But first, you have to give a full reading of that guideline. So let's start. So ovarian masses and cysts in premenopausal women, those women who are not uh, uh, in the menopausal phase. Up to 10% of women will undergo surgery in their lifetime for an ovarian mass. These percentages are very important. 10% of women they undergo surgery in their lifetime for an ovarian mass, and in premenopausal women, almost all ovarian masses are benign. And the overall incidence of asymptomatic ovarian cyst being malignant is it's not asymptomatic, it is a symptomatic ovarian cyst being malignant is. In the younger premenopausal women, the risk is 1 in 1,000 women, and by the age of 50, it increases to 3 in 1,000. So the risk increases with the age. This figure is important that up to 10% of women will undergo surgery, and by age 50, 3 in 1,000, the risk increases by 3 in 1,000. In turn, 10% of suspected ovarian masses are ultimately found to be non-ovarian origin, like mesenteric cysts or any other cysts. And how to manage simple small ovarian cysts. If the cysts are less than 50 millimeter, it means less than 5 centimeter, thin walled and cysts. These cysts are generally physiological cysts, which are normally formed during the period of menstrual cycle. And they usually resolve spontaneously within 2 to 3 menstrual cycles. So expectant management is recommended for these cysts if these are simple cysts. So how the assessment is done, we'll do history examination, investigations, and then we'll estimate risk of malignancy. Then we will offer the treatment to the patient. So in history, thorough medical history is taken and risk factors and protective factors for ovarian cancer are identified. For example, the protective factors are patients taking combined pills, or the risk factors are that she's a smoker or she's family history of ovarian breast cancer. We will inquire about symptoms of endometriosis. And to rule out possible malignancy symptoms, we will inquire about persistent abdominal distension, appetite changes, pelvic or abdominal pain, urinary urgency or frequency. These are symptoms indicating towards malignancy. On examination, obviously, we'll do abdominal and vaginal examination and check for local lymphadenopathy. And if there's acute pain, then you have to consider cyst complications like torsion, rupture, or hemorrhage. And sensitivity of detecting masses by examination is very low. between 15 to 51%. But if a mass is palpable, it is important to assess its tenderness, mobility, nodularity, and ascites. And CA1 to 5 is not needed for all premenopausal women if simple cyst is identified on ultrasound. So keep in mind if in exam a question come that a premenopausal woman has a simple cyst, the features of simple cyst are given. What will you do? You will not choose CA1 to 5. However, LDH, alpha fetoprotein, and HCG should be measured in women less than 40 years with complex ovarian masses. So these are offered in complex ovarian masses, not in simple cysts. So if there is simple cyst, you will not go for C1 to 5 or LDH, alpha fetoprotein, or HCG. Because the LDH, alpha fetoprotein, and HCG are offered with complex ovarian masses because these are the tumor markers for germ cell tumors, which are common in premenopausal women. So why CA1 to 5 in what is the significance of CA1 to 5 in premenopausal women? It's unreliable to differentiate benign versus malignant masses because it can be raised in fibroids, endometriosis, adenomyosis, pelvic infection, any condition that is leading to peritoneal irritation will lead to raised CA1 to 5. However, if high levels are found more than 200, then you have to consider referral to gynecological oncology. If the levels are less than 200, then investigate or treat common differential diagnoses, which are like endometriosis, adenomyosis. Serial monitoring of CA1 to 5 is required because rapid rise suggests malignancy and static levels are less likely malignant, and not required if clear ultrasound diagnosis of simple cyst, as we discussed earlier. And it's marker mainly for epithelial ovarian carcinoma, and it's positive only in 50% of the patients with earlier stages. And epithelial ovarian carcinomas are common in menopausal women. What is the role of ultrasound in assessing ovarian masses? The most effective tool is the pelvic scan, and TVS is preferred because it's higher sensitivity. However, if the masses are large or extra ovarian disease is suspected, then combined transvaginal and transabdominal approach is offered. And color Doppler generally doesn't significantly improve accuracy of assessment of these masses. And if there are some borderline cysts, then you can offer repeat ultrasound scan after periods, which will be helpful in identifying the physiological cysts from the pathological ones, because the physiological resolve after 2 to 3 cycles or even after periods in the same cycle, in the next cycle. And endometrial views aid in diagnosing estrogen secreting ovarian tumors because if the tumor is estrogen secreting, endometrium will be thickened, there will be endometrial hyperplasia. And no single ultrasound feature definitely distinguishes benign versus malignant masses. So there's no single feature. However, there's a mixture of these features that helps in differentiating benign from the malignant masses. What's the role of CT and MRI? It's not specific. However, it is useful for evaluating more complex lesions. And if on ultrasound examination malignancy is suspected, you have to refer to the patient to gynecological oncology multidisciplinary team. So how will you estimate malignancy risk in ovarian masses? There are different models to assess this risk. One is RMI, that is risk of malignancy index. It's most widely used. Then is IOTA, simple rules, ultrasound based. It has higher sensitivity and specificity. And CA1 to 5 has poor specificity in premenopausal women, so routine use is not recommended. So if CA1 to 5 has poor specificity, it means RMI also has poor specificity because RMI uses CA1 to 5. So in premenopausal women, the best thing to estimate malignancy risk in ovarian mass is IOTA rule, IOTA, which we'll discuss now. The risk models are simple models, intermediate models, advanced models. No one is going to ask you about these. I just added these models. You know what is risk of malignancy index? There are different types, RMI 2, 1, 2, 3, and 4. RMI 1 is usually used. In premenopausal women, what is the limitation of using RMI? It is less reliable due to endometriomas, borderline ovarian tumors, non-epithelial ovarian tumors, and other pathologies which have raised CA1 to 5. In non-epithelial ovarian tumors, CA1 to 5 is not raised. In borderline, it's not raised. In endometriomas, it is raised. And other pathologies which are not ovarian in origin, like peritoneal disease, any adenomyosis, or even fibroids, this can be raised. If one is suspecting ovarian malignancy, then NICE recommends RMI 1 score to guide management. If one is suspecting malignancy. So, what is the formula to calculate RMI? It is U into M into CA1 to 5. U is ultrasound score, M is the menopausal status, and CA1 to 5 is the reading of the tumor marker. On ultrasound score, 1 point is given for each of these findings: multilocular cysts, solid areas, metastasis, ascites, bilateral lesions. Ultrasound score is 0 if there is no lesion is found, no features are found among these, and it is 1 if one feature is found, and is 3 if two or more than two features are found. So the score can be 0, 1, or 3. And for menopausal status, 1 is for premenopausal and 3 is for postmenopausal. So if no feature is found in ultrasound, that cyst is not multilocular, there is no solid area, no metastasis, no site is a bilateral lesion, it will be 0 and the whole RMI will become 0. Serum CA1 to 5 is measured in international units per ml. If RMI 1 is score is more than or equal to 200, then its sensitivity and specificity is high. Sensitivity is 78% and specificity is 87%. These sensitivities and specificities you have to memorize. Although it's difficult to memorize these, but you have to because it's commonly asked in the exam. Then there's simple ultrasound rule or IOTA group. It is developed by International Ovarian Tumor Analysis Group. It is based on specific ultrasound morphological features without including CA1 to 5, which we read that it's not sensitive. Its sensitivity and specificity is less for premenopausal women. It has a high sensitivity and specificity for classifying masses. Masses are classified based on this IOTA classification into benign or malignant, and sensitivity is 95% and specificity is 91% in the premenopausal women. So it is quite high. So these are the rules, B rules and M rules. In B rules, these are for the benign cysts, and these are for the malignant cysts. So we have to, when we do ultrasound, we see these features. If and then we can estimate the risk of malignancy based on the features. If there are more features from the M rules, means ascites, four papillary structures, it means that the tumor is mass is likely to be malignant. If the features are in the fall in the B rules, then the mass is benign. However, if there are some features from the benign ones and some from the M ones, then you have to refer the patient to gynecological ultrasound specialist for further assessment. So how will we manage asymptomatic ovarian cysts? If the cyst is less than 50 mm or 5 centimeters, no follow-up is required. It's likely physiological, usually resolve within 3 cycles. Remember, we are talking about premenopausal cysts. If the patient is postmenopausal, the management differs entirely. So if it is 50 to 70 mm, then yearly ultrasound follow-up is required. If it is more than 70 mm, then consider further imaging, MRI, or surgical intervention based on symptoms and clinical situation. Sometimes it is found, cysts are found incidentally. And 4% of women, cysts are present in luteal phase, which resolve. COCPs, combined pills, have role in protection against ovarian carcinomas. However, it has no role in resolution of functional cysts. If the cysts have developed, then there is no role in resolution. COCP has no role in resolution of those cysts. Cysts that persist or increase in size after several cycles, what we do now, they're unlikely to be functional. So functional will usually resolve. So they might need surgical management. If cysts are complex like mature cystic teratomas, surgical intervention is required. And in surgical intervention, what is done? Cystectomy is done usually. However, depending upon the clinical situation, sometimes oophorectomy needs to be offered. And we know that for benign cases, laparoscopic approach is better because low morbidity, shorter recovery time, cost effective. However, if the masses are large with solid components, then laparotomy may be required. Sometimes cyst is aspirated. However, it is less beneficial as leads to high risk of recurrence. And while doing surgery, avoid spillage of ovarian cyst contents because if these are found to be malignant, there's a risk of spreading malignancy. In chemical peritonitis from dermoid cysts, spillage is rare, 0.2% of cases. This question can also come. And use a tissue bag to prevent peritoneal spillage. So retrieve the specimen in a tissue bag. If spillage occurs, perform peritoneal lavage with large volumes of warm fluid and avoid cold irrigation fluid and remove solid contents carefully using an appropriate bag. So discuss the possibility of ovary removal with the woman before surgery, especially in those women who have family history of ovarian carcinomas or breast carcinomas, or who have risk factors for in their personal history for ovarian cancers, or if they are around more than 45 years of age. It will depend upon the scenario of the patient. Or if from the look during surgery the cyst seems to be borderline or malignant, then you should have informed the patient that you might need to remove her ovary as well. And if you're doing laparoscopy, prefer removal via umbilical port because it leads to less post-operative pain. So now we start doing quiz. Ramin, I will request you to use Slido. What you have to do is open your Chrome and write slido.com there. If you have joined, please let me know.
Um, yes, they're asking for the code. I don't have any
Yes,
code,
this is the
so
code 2349279. Can you
okay.
see the code on my screen?
Yeah,
Yes. Enter this code. Have you entered?
yeah, I'm just writing my name.
All right. Well done. So here comes the first question. You can read the
Okay.
question on your mobile screen or here as well.
Yes.
Now you
Should I
have to
read
choose
it loud or okay?
the best option. No need to read it aloud. Just choose the best option for that. Cyst size is 10 into 9 centimeter and features are of simple cyst. What will you do?
I um,
Done?
yes.
I think you answered follow-up ultrasound.
I chose the ultrasound, follow-up ultrasound.
Yes, but cyst size is 10 into 9 centimeter.
Yeah.
So the correct answer was cystectomy because cyst size is more than 7 millimeter,
Yes.
70 millimeter or 7 centimeter. We will offer surgical removal.
Ultrasound. Okay, surgical removal.
Surgical
Yeah.
removal. If it is from 50 to 70 then we will do follow-up ultrasound. So let's move
Okay.
to next question. All the statement of the next question is same except the last three lines. Okay.
Okay.
So this is the next question. Size is different. It's 4 centimeters.
Yeah, it shows no follow-up required.
Good, good. That's the correct answer. Because if cyst is less than 50 millimeter, no follow-up is required.
Okay.
Next question, only size is changed. It's 7 centimeter.
Now I
Good.
think it would be ultrasound.
Yes, good.
Yes.
So next question scenario is same. Cyst is 7 centimeter. What is the best indicator which will help in managing and triaging the patient or estimating the risk of malignancy? Remember, she is a premenopausal woman.
Yes.
Done?
I think aorta. Yeah,
Yes, good,
aorta.
good. So you saw that we discussed the important things, and
Yes.
these kind of questions usually are asked in the multiple choice questions or in the EMQs. Same scenarios are given with only minor changes, like sometimes size of cyst is changed, sometimes patient's age is different, and you have to choose the best option. So you have to clearly identify the highlights of the question. All right. So what is regarding the last question? RMI is the most widely used model, but recent studies have shown a specific model of ultrasound parameters. The ultrasound rules, which are derived from International Ovarian Tumor Analysis Group. Although RMI is simple and reproducible, but its utility is negatively affected in premenopausal women, as we discussed that CA125 is raised in many other conditions as well. And the sensitivity of iota is 95% and specificity is 91%. However, sensitivity of RMI1 is 78% and specificity is 87%. So we can see that sensitivity and specificity of iota is more than RMI. So this was quick review of how we'll do it in the course. In the course, I will discuss with you the summaries, and we'll have 2 live sessions in the week as well to stress upon the difficult questions and the commonly asked questions in the exam. There are different types of courses. The basic or quick revision course, it offers uh, you have to do the you have to cover the syllabus by yourself, and by the end of the week we will do the recalls or the important questions that can be asked from those topics. And other courses, they offer more help and more guidelines are provided, summaries are provided. You can choose the best course according to your feasibility. And then there's 15% discount on subscription of all courses till 15th July. Starting date will be 20th July. If you have any question, Rami, you can ask here, or you can even text me.
Yes. I have one question. I want to ask you,
Mhm.
what would be the perfect timing? I mean, I'm just starting the preparation.
Mhm.
So, what would be the ideal timing for me to join the course? Should I start joining now, or should I just wait and study by myself and then join?
If you think that you can study by yourself,
No,
then
I'm just starting. I'm just
I,
starting. I don't know
I
how
think you
much do
should.
I need.
I think you should join a course. I'm not insisting that you should join my course. You should join any course
Okay.
because those students who have recently done FCPS Part 2 exam, I would recommend that they should join any course which just offers them some assessments or practicing the questions. But for those people who haven't recently attempted Part 2 exam, like for you, most probably you will read the guidelines for the first time.
Yes.
So it will better that you start by now and join any course which offers you help or discussion on these guidelines, because it's very difficult to retain the knowledge from these guidelines. You saw that I try to include all the important points from these guidelines, and the questions are asked in the same manner in the exam. So if you are reading these guidelines by yourself, it's difficult to highlight these important points,
Yes.
right? So it would be better that you join any course, or if you don't want to join any course, then there should be a study buddy with you so you can do a discussion with them.
Yeah. Okay.
So if you have any other question, you can.
Yes.